So again, it's my, that was a great talk. It's my pleasure to introduce Dr. Harriet Kluger. Dr. Kluger has been my partner in the clinic for nearly 10 years. She's an outstanding investigator. She's a world's expert in development of molecular markers for melanoma, has her own laboratory, and has developed specialized programs for treatment of brain metastasis here at Yale. She does a lot more than just work in the lab and take care of patients. She's also a leader in the education of our fellows. She mentors many students and fellows in her lab, so she has more energy than anybody I've ever met in my life. So with that, I'd like to introduce Dr. Kluger to talk about molecular markers and approach to personalized treatment.
So thank you, Mario. Thanks for the lovely presentation, and I'd like to thank everybody for staying so late tonight. So Mario said a few things that weren't quite accurate. He said I don't listen to him, for a start. He also said earlier that I'm going to be talking about new therapies, but in fact I was asked to talk about melanoma markers and approaches to personalized treatment. So I'm going to try to do what I'm supposed to do, and that's listen to him. And I'll try to touch on some of those newer therapies and kind of go a little bit out of sequence to what's actually mentioned in the slides. I can't find the slideshow. Is this it? Okay, thank you so much. And then the other thing that he said that was inaccurate, that I have more energy than anyone that he knows. So just so everybody knows, when we rode the 25-mile bike ride, at the halfway point, I texted him because I was worried that I hadn't seen him for, like a half an hour or an hour. And his response to me was, I'm already back at the finishing line and I'm going to work out. So it's not quite true. So we'll move along and start to talk about treatment for unresectable melanoma. So essentially what we do as oncologists, Mario and myself, is treat patients whose lesions are not resectable by the surgeons. And by definition, that means that's when the melanoma cells have spread beyond the initial site. So if it's a skin melanoma, it would be the skin. Mucosal melanoma would be the mucosa, and the uveal melanomas are beyond the eye, but also beyond the draining lymph nodes. And so in these situations, you can't really go in and resect site by site. We presume that cells got to these distant locations via the bloodstream. So you have to give systemic therapy. And by systemic therapy, we mean therapy that gets to all different parts of the body. These are usually IV therapies or pills. When we do this, we can either treat the melanoma cells themselves, or we can treat the environment around the melanoma cells, so immune cells, blood vessels, and so on. So the problem that we have when we select the appropriate therapy for an individual patient is how to sequence things and which therapy to offer which patient. So until 2011, in terms of approved therapies, we didn't really have a problem because there was nothing for us to do. We had high-dose interleukin-2 that's very effective for a small subset of patients. When that doesn't work, we had a few chemotherapy drugs that we could use, but essentially we had very little to choose from. Since 2011, a bunch of drugs have been FDA approved. They're listed over here: ipilimumab or Yervoy, vemurafenib, dabrafenib, trametinib, pembrolizumab was the newest member on the block just a week ago. And there are other drugs that definitely are active in this disease that are currently in clinical trials. So not only do we have to choose from a menu of FDA-approved drugs, we also have to choose from the clinical trials. And sometimes via clinical trials, we have access to new drugs years before they're FDA approved, and I'm sure there's some people sitting here in the audience who are treated with some of those. And I can see some people nodding at me right now. Thank you. And the other reason to treat people on clinical trials is this is the way we're going to learn, this is the way we're going to advance the field. And without trying new things, we would be back to where we were in 2003. So, as I said, we could either target the cancer cell or we can target the immune therapy. We could target immune cells. I've listed some bullet points here, the pros and cons of the two different approaches. So, cancer cell targeting often requires specific mutations. Ruth has mentioned mutations in BRAF and NRAS, and there are a few others that will be targeted in the future. They're often very effective in a high percentage of patients whose tumors harbor those mutations, and they often work quickly. So sometimes it's a really good choice if we have to do what we call chemical debulking of a tumor, give a drug, get the tumor burden down very quickly so that we can administer other therapies. The problem is the tumor cells are smarter than our drugs, and they tend to become resistant to these therapies with time. One big advantage is that many of them are pill form, so it requires a little bit of freedom from the oncology clinic. When we target the immune system, we do not require specific mutations as far as we know, although this may change as we become smarter. Some of these therapies require specific tissue types, so it requires that a patient is born with a certain genetic trait, and that's specifically in reference to adoptive cell therapies when we give patients engineered cells to fight the cancer. Sometimes these therapies take a while to work, so we can't do it for patients right away who have aggressive disease or a large tumor burden, as we call it. But the advantage is that sometimes when these drugs work, they can work for a very, very long period of time. And I think Mario and I can both attest to the fact that now in every clinic day we see about 4 or 5 old friends, as we call them, and that we're referring to people who got immune therapy 2 years ago, 3 years ago, 5 years ago, come in every 3 months, we chat, we get to know each other, it's a social visit. We scan people, of course, too, but we're not actively treating them. They've had metastatic melanoma. Some of them we would even say have metastatic melanoma because you can see things on their CAT scans, but they're not on active therapy. The other thing, though, is that in general, these therapies often will work on a smaller percentage of patients than the targeted therapy will. So this is just a little cartoon, and I don't want to get into too many technicalities, but it's a cartoon of a cancer cell, or in this case, a melanoma cell. So you've got the membrane of the cell and all sorts of proteins inside the cell that are responsible for the mechanism of the cell, so for growth of the cell, for division of the cell, and survival of the cell. And we've heard about BRAF mutations. Those are the most common mutations in melanoma, so when the BRAF is mutated, it's activated all the time, and it keeps the cell going in this mode of proliferation, growth, and survival. NRAS mutations are actually in the same pathway, and we just heard about the third important mutation, NF1, which also, in essence, activates the same pathway. So if you were a drug manufacturer and you wanted to develop a drug, you could either develop a drug that binds to activated BRAF, which is what happens with vemurafenib and dabrafenib. There's some technical difficulties with targeting NRAS, but you can also target downstream. So you can target MEK, you can target ERK, and so on. And as we learn more and more about these pathways and how they talk to each other and how the proteins overcome, or how the cells overcome the drugs with time, we're going to get smarter and smarter at targeting parallel pathways and downstream of the initial mutation. So essentially, in the beginning, we thought, great, we've got BRAF mutations. It's a specific mutation called V600E, and all the patients who were put on the initial trials with the BRAF inhibitors had to have the specific mutation called V600E. And then this is work done by Ruth, there was a patient who had a slightly different mutation called V600K, where the amino acid that was mutated was just slightly different. And this patient actually got onto a clinical trial by mistake. And sometimes the best things that we learn are from these mistakes, because in essence, this is the response. These are the tumors before and these are the tumors on therapy. So we learn a lot by these clinical trials and by going back and looking at the specifics of the sequencing in a very meticulous way, just as Ruth described to you earlier. So we can do personalized medicine for BRAF mutant melanomas. We've gotten pretty good at that. We know that we do not see responses in patients who do not have mutations in BRAF. These drugs actually may be harmful in those patients. The assay or the test that we use is very reliable. It's reproducible about 90% of the time. It's not 100% of the time, and that's how that other patient got onto the trial by mistake, because the assay wasn't perfect. But the problem with it is that we can't differentiate between patients who are going to have an 11-month response to therapy, a 5-month response to therapy, or a 2-month response to therapy, or even a 3-year response to therapy. So we've got to become more and more sophisticated at identifying other mutations within the cell that may give us information on the drug resistance, as Ruth mentioned earlier. So there are lots of studies ongoing at Yale, including in the SPORE and elsewhere, to try to identify those patients who are going to have a very brief benefit from these drugs and try to develop drugs to overcome those mechanisms of resistance. And there are lots of clinical trials underway. We're now starting to target not just one mutation in the cell, but 2 or 3, and so on. So what about the other mutations? The next most common one is NRAS. We don't know how to target this. It does seem that patients with NRAS mutations might respond a little bit better to standard chemotherapy or to high-dose interleukin-2, but this still needs to be validated in additional studies. There are mutations in another protein called c-KIT. These do respond to c-KIT inhibitors. Unfortunately, they're quite rare. And another area that still requires intense research is uveal melanomas. We do not have any good drugs yet for the common mutations that are seen in uveal melanoma. So I'm going to switch gear a little bit now and talk about immune therapy. As I said, we could target the cancer cell or the immune cells. So high-dose interleukin-2 or interferon were the older immune therapies. We do not know how to predict who's going to respond to high-dose interleukin-2 and who is not. And this is a big problem because we bring a lot of people in for this therapy, and those who respond oftentimes are golden for many, many years. But it would be nice if we knew who was going to respond and who wasn't. Adoptive cell therapy, I mentioned earlier, it's a means to take T cells either from the blood or from the tumor and to modify some genes within those cells to teach the T cells to attack the cancer. So you take the T cells out of the tumor or out of the peripheral blood, you engineer them outside of the body, and then you reinfuse them at some point. There are other vaccines that are under development in the United States, and then there are the famous immune checkpoint inhibitors. So Yervoy, ipilimumab, anti-CTLA-4, that's been mentioned a number of times today, inhibitors of PD-1 or PD-1 ligand, or the second group, and then there are many, many others that are in development, and I think we're only starting to discover the tip of the iceberg here. So this is a cartoon that I stole from Mario a few years ago, and actually I have a typo there, just pretend this word inhibitor isn't there, but I call this older immune checkpoints because these were the ones that were well characterized about 5 years ago. So we had CTLA-4, we had PD-1. These are molecules that inhibit the T cell when they come into contact with a cancer cell. PD ligand 1 is on the cancer cell, and the arrows here showed the ones that we initially targeted and we knew about a few years ago. But in fact, if you look very carefully at this cartoon, the other ones mentioned here, CD40, OX4, many of these can either be stimulated or inhibited, as the case may be. This is a more modern cartoon, a more contemporary one that was that I took from a manuscript written by Liping Chen last year. And now you can see that there are many, many more of these characterized, and all the circles actually represented those that were being targeted in clinical trials about a year ago. But the field is continuing to move forward, and more of these are now being studied, such as an antibody to OX40 and so on. So the question is, how can we predict response to the immune therapies? Because there too, not everybody responds. People that respond often will respond for a prolonged period of time. It would be wonderful if we could select out those that are going to respond to one drug, give them one drug, those that need an additional stimulus, and give them more toxic therapy. So there were many attempts made over the last decade to predict response to ipilimumab, and I'm not going to go into all of the details, but the reason that these attempts were made was that the response rates are quite low, around 15%, although when patients respond, they tend to respond for a long time. And of course, the drug isn't candy either. We see a lot of toxicity. So it would be nice to be able to sort out the responders from the non-responders before we actually try to treat a patient. So large efforts were made, but to cut a long story short, papers were published, results were never validated because the field of immune therapy had moved on quite quickly, way beyond ipilimumab, and nobody now wants to spend millions of dollars predicting response to ipilimumab. Now everybody wants to predict response to anti-PD-1. So that's the next blockbuster drug. We do think that expression of the ligand to PD-1, called PD ligand 1, on tumor cells might be associated with response to therapy. So there are lots of tests, lots of different antibodies that are used in patients' tumor. They're not all that reproducible. There are a lot of technical problems with these, but most of the studies do show what we're seeing here in the graph on the left, that patients who get anti-PD-1 who are positive are more likely to respond than patients who are negative. So for example, in this particular study, 7 out of 17 patients who had expression of the biomarker responded, as opposed to 3 out of 21 who were negative for the biomarker. When we give it together with ipilimumab, this doesn't seem to matter anymore. In fact, if you focus on when you give it in combination at the same time, it looks like the response rate is almost the same in the positive and the negative patients. So if we're going to be moving forward to giving combination therapies, perhaps it doesn't really matter whether the patient's tumor expresses the biomarker or not. And this is just an example, actually, that I lifted from the renal cell cancer world, where tumors are bigger and it's easier to study these things. When we say a tumor is positive for PD-ligand 1, we need to ask the question, well, how positive is positive? How many of the cells need to be positive within a tumor? What happens if you biopsy in one area and not in another area? Maybe you're going to miss it because the expression is not homogeneous across the tumor. So this graph here is from patients with kidney cancer who had given us primary specimens for evaluation as well as metastatic sites, and you can see that the expression in the metastases was higher than in the primary, so it's definitely not exactly the same. There's something of a correlation. It's pretty weak, but in fact a lot of them were really very heterogeneous. So we took 4 different biopsies from different areas of the tumor. Some patients had homogeneous expression and some had heterogeneous expression. It's very difficult to know what to do with all of this information. So although we think that expression of PD-ligand 1 enriches somewhat for activity of these drugs, the question is that there's a subset of patients who are going to be negative. Do we want to not offer them the opportunity to get a PD-1 inhibitor? And what about all those patients who are positive who still don't respond? We're treating them unnecessarily. So we have to do better in terms of the biomarker. We also think that in the case of immune therapies, we shouldn't only look at the tumor cells themselves. We've got to look at the environment as well. So it's not good enough to have an immunogenic tumor if you don't have any T cells there that are going to work, or immune cells. So you've got to characterize the immune cells. So it's becoming incredibly complicated to predict who should be treated with one drug and who should be treated with another drug when we're talking about immune therapies, because we've got another layer now of tests that we have to do on a patient specimen. So probably ultimately in 10 years' time, we're going to be laughing at what we're doing now, because we're going to have very fancy tests to predict response that are going to include blood markers, tumor markers, T cell markers, melanoma cell markers, and so on. But the good news is that we're seeing many, many more responses. We've got more active therapies. We've got more therapies to study, and we really need help of patients. And particularly at Yale, our patients have been very generous with contributing their specimens and their blood samples to this research so that we can actually start studying all of these things. So in conclusion, I'm going to say that the therapies for metastatic melanoma have dramatically improved over the last few years. Now more than ever, we need biomarkers to predict response because we've got a menu of drugs to treat from. To date, the best assays have been the mutations, the BRAF mutations. They're very reproducible, but even those aren't perfect. And to do these studies, we need very good sample collection, and we need to have validation of analysis in different institutions. But we do think that trials are still necessary, and they should include these biomarker studies, whether they're retrospective or prospective. We've got to be very careful with analyzing and interpreting the data. And I think I'll stop there and just thank everybody who participates in all of these studies, first and foremost patients and their family. There's the clinical research unit, the pharmaceutical collaborators, the basic research collaborators, and of course the larger melanoma research community in the United States that's typically very collaborative. And I'll stop there. I think that we're going to move to questions.